let's do our last case, another screening, just to keep on the theme. And now I'll just go to mag views because we love mag views here. Okay, and let's do the question, and I'll scroll back once the question shows up to that last image so you guys can look at it. Okay, and let me move this off to the side a bit. Hopefully you can get a good view with it there. Excellent. And everybody said, 75% said Lucent Center BI-RADS 2 annual screening, 25% said course heterogeneous calcifications, BI-RADS 2. So let's talk about it. And let's see if I forget now. No, I did do. So there's skin calcification. I had a moment of senior moment where I couldn't remember if I had a second question or not. So these are skin calcifications. And we just talked about it, right? So these are what they look like. These are the round, right? We said things that are round and don't look irregular are benign. We see the Lucent Center, how they kind of look like Cheerios. I don't know, for those of you that have children, I think I've seen my share of Cheerios when my daughter was a toddler, and they kind of look like that. And these are in the skin, and they're benign. Coarse heterogeneous, I would expect them to be more irregular. Okay, let me go to my other things. And coarse heterogeneous would never be a BI-RADS 2. Okay, so that answer was out right away, because coarse heterogeneous should never be a BI-RADS 2. We said it was a concerning descriptor in the last case, thus it would be a BI-RADS 4, right? And we would recommend biopsy. Pleomorphic calcifications would be a BI-RADS 4, and we recommend biopsy, but these don't look like those punctuation calcifications from the one before. Amorphic calcifications, you know, usually off of a baseline, you biopsy amorphous calcifications. The only things we don't biopsy off of a baseline mammogram and would do a BI-RADS 3 for would be punctate grouped calcifications. So this really wouldn't be right, and these aren't amorphous calcifications. Amorphous are like very fine and hard to see, and they just aren't perfectly punctate, so this wouldn't meet that. So this is Lucent Center calcifications, annual screening mammography, skin calcifications. Skin calcifications usually occur especially in the intraderous areas, like in the cleavage and underneath, because of debris and incrustated debris that calcifies in pores. And you can also see them a lot of times in incisions, especially reduction scars. You can see them around the nipple and at 6 o'clock from reduction scars due to incrustated debris and other things in reduction scarring. So those are common places to see them. If you ever want to prove their skin calcifications despite magnification, you would do, as I spoke of before, tangential views. And that's where you get them in one view, put a BB, and then you put the beam tangential to the BB, and it will show if they are in the skin that they're within the skin on the tangential views. So that's how you could prove it if you weren't 100% sure of the morphology. And that is it for my cases. Thank you, everybody. Case number 10, history is screening. Okay, and now, because calc cases are always notoriously hard on projections on PowerPoint, I've provided you with some additional images. And to be extra kind, a few extra images. So now I'll go to the question, and I'll scroll back so that once the question pops up, so you can continue to look. Hold on, sorry. There you guys go. 75% said coarse heterogeneous, 25% said lucent, no one said large rod-like, and no one said pleomorphic. I'm not going to give you the answer yet because I want you to answer the next question. And I'm happy to go back to the images again. All right, and 50% of you said ductal carcinoma in situ BI-RADS 4. Okay, and 50% said skin calc. Let's go back to the case. So I want you to notice that the calcifications are at about 12 o'clock in the right breast here. They're very hard to see, right? So remember, I was doing you guys a favor by magging those up because it's so hard to see, and normally you can mag them up yourself. But you want to judge if they're fine or coarse based on the non-magged mammogram, right? So these are really hard to see. So I wouldn't quite call these coarse. I would think these are fine. Then we mag them, And we see they're all different shapes. So I call these punctuation calcifications or shrapnel calcifications. And so punctuation calcifications, I call them that because if I look closely here, and I think I like my next image even better down here, okay? This looks like a parentheses, this looks like a comma, this looks like a period. I think there's another comma here. It looks like a colon. So it looks like someone hit all the punctuation keys on the keyboard. And so that's multiple different shapes. And that's the definition of pleomorphic. And I also call them shrapnel calcifications because it almost looks like a bomb goes off. And so if a bomb explodes and shrapnel goes all over the place, it's in all different shapes and sizes. It's not uniform, right? And is a bomb a good thing or a bad thing? It's a bad thing, right? So that's how I remember this. Shrapnel calcifications, all different sizes of shrapnel, bad, DCIS, okay? So these are pleomorphic calcifications, and they're caused by usually high-grade DCIS with chemotonecrosis. And again, necrosis, when things are benign, they tend to push and grow very uniform and look very symmetric. When things are malignant, there's invasion, there's necrosis, it's irregular, right? And so that's what this is. So I want to go over the answers. So these are not large rod-like calcifications, right? Large rod-like calcifications describes secretory calcifications, and they're usually emanating from the nipple. It's benign, it's caused by plasma cell mastitis, and you usually see them symmetric and again radiating from the nipple. We just talked about pleomorphic. Lucent center calcifications is a benign descriptor, right? So this is where you really need to know your BI-RADS. Lucent center is a benign descriptor, and these are those donut or Cheerio calcifications where they're round, they have a lucent center. Usually if you do tangential these, you can localize them to the skin. Coarse heterogeneous, I know that is a confusing thing for pleomorphic calcifications, but actually I've done this case many times. I've actually never had the confusion from my participants before, so now I'm going to learn to put another slide to show you guys what a coarse heterogeneous calcification is in the answers so that we can learn about that. But they're much easier to see, much easier to see, and they almost look like developing popcorn calcifications, okay? So definitely not as fine. Pleomorphic are more fine, okay? But both pleomorphic and coarse heterogeneous are concerning descriptors, right? Whereas large rod-like and lucent are benign descriptors. So this would be DCIS, which is a BI-RADS 4. Skin calcification would be those lucent center, and they would be a BI-RADS 2, okay? So now we have a 40-year-old postpartum, note she is lactating, female with a new right breast mass. All right, go to the question. So what is the least likely diagnosis from the answers? And I'll go back and I'll move this over so that everyone can see. All right, looks like we have our answer. All right, so we have a bunch of different opinions. It looks like a third. So no one thought abscess, but a third thought focal mastitis, a third IDC, and a third galactocele. All right. And then what is the risk of biopsying a patient with, what is the risk of biopsy in this specific patient? And we'll get to all the answers at the end. All right, a milk fistula. Excellent. So to talk about the first question, the least likely diagnosis, I want to first describe it, and then we're going to go to the differential, and you'll see why all of these are on the differential, but one is very unlikely, but it's important to keep it in mind. All right, so we have a mass of multiple different echogenicities. We have some areas of fluid. Not a ton of hyperemia, but there's a little bit. So, you know, mastitis, you expect to see a lot of hyperemia. You also, with an abscess, sometimes you can see hyperemia, sometimes you don't. Galactocele, you wouldn't expect hyperemia. A galactocele and an abscess can both be a complex mass with cystic and solid components, as well as mastitis can also get some fluid from edema because there's not a ton of drainable fluid here, it looks like. And then, of course, you're always concerned about invasive ductal carcinoma, which could, if it was necrotic and a rapidly growing tumor, it could have focal areas of hypoechoic focal areas representing necrosis. So when we go to the differential diagnosis, the most common things in a woman of this age and lactating is a galactocele, a lactating adenoma, an abscess, or focal mastocytosis. So those are the most common. Yes, breast cancer can occur. The percentage is low, and that's why it's the least common. So it's important to always go to these first while keeping breast cancer in mind. And the reason you don't want to automatically jump to this is cancer is because biopsying these patients is difficult. You can give them a milk fistula. And what happens with a milk fistula is when you biopsy a mass in a lactating breast, you can cause a fistula between the milk ducts and the surface of the skin. And what will happen is the milk will take the path of least resistance. The nipple has a lot of resistance, right? If not, the milk would just squirt out all the time. But it has some resistance to maintain their smooth, erectile smooth muscle in the nipple to keep the milk in. But there won't be any at your biopsy site. So the milk will go out the fistula, the biopsy site, and it won't go out the nipple. And what will happen is the patient will have to stop breastfeeding because the baby won't breastfeed anymore on that side because they won't be getting milk, and eventually the milk will dry up. So you really want to think twice before biopsying. Now, if you do have a high suspicion that this is one of those small percentage of pregnancy-related breast cancers, what you want to do is you don't want to use your typical biopsy device. You don't want to use your typical 14-gauge spring-loaded biopsy device or large bore biopsy device. My recommendation is to do an FNA with a 21-gauge needle or less. And what that'll tell you is, are there malignant cells in here or not? If there are malignant cells in there, then you proceed to a core biopsy because breastfeeding is the least of the patient's problems, right? And if you get a milk fistula, it'll be worth it because the patient needs her breast cancer treated. But you'd hate to give someone a milk fistula if they have something benign like a galactocele. A lactating adenoma looks very different from this. It's usually circumscribed. Essentially, it looks like an fibroadenoma. But you would hate to give someone a milk fistula and cause them to not be able to nurse for a very low percentage of breast cancer. So that's why if you have a suspicion, start with a small needle FNA. Case number 8, the only history you have is screening. We'll go to the next image. Okay. I'll go on to the question. We can come back to the images. Okay, so let me go back a slide. I think we'll stick with the ultrasound. And then I'll flip back to the mammogram for those who are interested to see that as well. Excellent, everyone got it. Invasive ductal carcinoma with metastatic disease to the axilla, and it would be virus 5. And so on here we have this asymmetry in the upper outer right breast with multiple calcifications. So yes, there is probably a component of DCIS in it, but you know the important thing here is this is invasive disease. And then harder to tell, you can't really see the axilla, the nodes that well on the mammogram, but when they have the ultrasound, we see this irregular mass with a feeding vessel, hypoechoic with posterior shadowing. And then when we look at the axilla, we see this lymph node that has a hypoechoic cortex, but we see that the cortex is thickened. So the normal cortical thickness is 3 millimeters, and it's up to 8 here, and it's focally thickened. You can see here it's probably about normal, and so focal thickening, and here you can see characteristic rat bites, kind of, where the cortex is going into the hilum. The hilum's the echogenic area, the hypoechoic area is the cortex. You can kind of see this focal little, it looks like someone's taking a bite out of the hilum, and this is very concerning for metastatic disease. Versus if it was uniformly thickened, you think more of something systemic reactive, something like that. So very good. This and of course this we know is a cancer, right? We don't even have to question that. Our next case is a 61-year-old female, status post-right mastectomy, transplant reconstruction, and she now has a new palpable in the transplant. I'm going to go on again. This is the mammogram of that right transplant. The same breast as the palpable where that ultrasound was done. We'll go to the question. Go back to an image. Go back to the ultrasound. Not sure what people find more helpful. Wonderful. 100% of you said fat necrosis. And that is correct. So this was fat necrosis in a tram flap. The differential diagnosis for palpables in a tram flap are fat necrosis, fibrosis, scarring, seroma, or recurrent breast cancer. Seromas tend to occur more close to post-op, whereas fat necrosis, fibrosis, and scarring tend to be distant, and of course, breast cancer recurrence can occur at any time. So what we saw here is we saw this kind of macro lobulated hypoechoic mass with some echogenicity in it as well. There is some shadowing. And so this looks, you know, with the mixed echogenicity, some hypoechoic, hyperechoic shadowing, I was wondering, you know, it suggested maybe this is fat necrosis. So we did a mammogram of the area to confirm that we have this, what we're starting to see eggshell or calcifications forming around fat lobules, which is pathognomonic for fat necrosis. DCIS, we would have seen pleomorphic calcification. The fibroadenoma, we probably wouldn't expect to see because the patient's had a mastectomy and there's not much breast tissue, but you never know. And that would usually look like a popcorn calcification if we had, you know, a circumscribed mass on ultrasound, and if it was calcified, it would be a popcorn calcification on the mammogram. And then skin calcifications, we probably wouldn't even see those on ultrasound, so we really wouldn't expect that. But if we had just seen the mammo, they would look like lucent-centered calcifications, almost like little Cheerios, very well circumscribed. All right, number 6, we have a total of 11 cases we're going to try to get through. Looks like we're doing pretty good on time. High-risk screening MR. These are sequential images in the same breast. Patient had a negative recent mammogram. These are the kinetics. So what you're seeing here is those that were sagittal images of this axial image. We'll go to the question. Which of the following is not in the differential diagnosis for this MRI finding? And I will go back to show, I'll go back to show you the images. Excellent, and 67% of you got it correct. Fibroadenoma is not in the differential diagnosis for this MR finding. Let me just make sure. So what we see here is non-mass enhancement, and the differential for non-mass enhancement is DCIS, invasive lobular carcinoma, LCIS, fibrocystic change, inflammation, or focal adenosis, okay? A fibroadenoma would be mass enhancement. So you would see fibroadenomas are classically enhancing masses with non-enhancing septations with circumscribed borders. So as you can see here, we have this non-mass enhancement. You can't really make defined borders out of it. There's some intercalating fat if you look here. So this is non-mass enhancement. And so you do the differential for that. Again, a mass would have defined borders. So again, classic differential, DCIS, ILC, LCIS, fibrocystic change, inflammation, and focal adenosis. 40-year-old female with silicone implants. I will go to the question and then scroll back for you. Excellent. Intracapsular implant rupture on the left. Wonderful. I just realized I probably should have put a left-right marker, but you can vaguely see the heart to help you. So intracapsular implant rupture. What this was the linguini sign. So you can see all these these dark lines. This is a silicone bright sequence, and you can see all of these dark lines here that are black, low signal lines, and those are called the linguini sign, and that is the silicone capsule that has ruptured and now is floating in the silicone. But there's no extracapsular rupture because the silicone is still contained within the fibrous capsule. And you really want to, when you see an intracapsular rupture, look really good on all images. Of course, I don't have all the images here, but you would scroll through and be very careful to make sure there's no extracapsular silicone. So, 58-year-old male with HIV and a palpable left breast mass. Here's the images. And the mass is marked with a palpable BB right here. Every institution does something different. The institution I was at when I found these images, it was a BB marker. Some places use a triangle, but in this case, it's a BB. So this is the first set of images. This is another set of images. And this is the ultrasound of the left palpable area. All right, we can go to the question. And I'll scroll back to, I guess you can scroll back to the mammogram to keep it on the screen for those that want to take a second look. Bilateral gynecomastia, very good, correct. So we see that there is retroareolar flame-shaped tissue, and the BB is right on the flame-shaped tissue. It's really important that if the BB is not on the gynecomastia, that you don't say the palpable is caused by gynecomastia. If the BB is not on gynecomastia, directly on the gynecomastia, you have to investigate it further. So normally what I do, if a patient is over 25 with gynecomastia, you start with a mammogram. And really gynecomastia is a mammographic diagnosis, and you don't have to do the ultrasound. You want to just spot the palpable area, which we did, to make sure there's no underlying mass, and there isn't. And right, the scary thing about gynecomastia is it looks irregular, it's flame-shaped, but it's retroareolar. You want to make sure it's central to the nipple. If it's ever eccentric, then you're concerned for a mass. And on ultrasound, you see there's some breast tissue right behind the nipple, consistent with gynecomastia, corresponding to the palpable. And I answered this accidentally. Was ultrasound necessary? Let's see if you listen to me. And good 100% of you listen to me that ultrasound is not necessary. So bilateral gynecomastia, this guy, the hint was in the history, he had HIV. And so if someone has a known diagnosis of HIV, they're usually on HIV medication. And so causes of bilateral gynecomastia are HIV medications, antiretrovirals, lots of other medications, cimetidine, anabolic steroids, spironolactone are also causes. Another thing is anything that increases the estrogen in a man's system, such as cirrhosis and liver failure. Marijuana, it's a big one. Actually, it's a big thing when I see teenage boys that they get very, when I tell them smoking marijuana can cause it, it's a very easy way to get them to stop smoking. And then very rarely breast cancer. This is on the official differential diagnosis. I've never seen this bilateral breast cancer in men. It is almost always gynecomastia. So now we have a 63-year-old female presenting for a screening mammogram. These are our only images. I'll give everyone a little time to look them over. Trying to make sure everyone has enough time. I'm sure I don't know if there's a feature for you to tell me, a chat feature if you don't, but we'll move on. So what is the finding on the mammogram? Bilateral axillary adenopathy, correct. So I'll show you guys right here. We can see bilateral symmetric axillary adenopathy. They're enlarged, hard to see the hilum. So these are not normal. So bilateral axillary adenopathy is completely correct. What is the appropriate BI-RADS category for this finding? And please remember, this is a baseline mammogram, that we don't have another prior mammogram. Exactly, it's BI-RADS 0. If these were stable for multiple years and you knew a cause of these, it would be BI-RADS 2, but because this is a baseline and we have nothing to compare it to and we don't know if these are new or not, this is a BI-RADS 0. So now, what is the appropriate workup for this finding? Exactly. Bilateral axillary ultrasound is the next most appropriate workup. So, and we'll talk about the hematologic workup in a minute. But what is a common diagnosis for the finding on mammogram given the patient's age? CLL, that is correct. So the differential diagnosis for bilateral axillary adenopathy is CLL, most commonly seen in older women. So this patient, I think if I'm remembering correctly, I said 63 years old. So older women, it's usually CLL until proven otherwise. HIV, if you catch, and this is typically in a younger person, not to say older people can't get HIV, of course anyone can get HIV, but a younger person is less likely to have CLL. The first thing you would think is that they're in the acute retroviral phase of HIV and having systemic adenopathy. A bilateral axillary adenopathy can also be seen with granulomatous diseases such as sarcoid and TB, and collagen vascular diseases such as RA and systemic lupus. You're always going to go with a systemic disease when you see bilateral axillary adenopathy first, because that's the most common thing. Metastatic disease from breast or non-breast can happen. Usually breast metastatic disease is seen in unilateral axillary adenopathy. However, it's widely metastatic and has really, you know, as we say, the cat's really out of the bag. You can see metastatic disease in the axil on the contralateral side. Of course, there are things like other cancers like lung cancers or melanomas and things like that, where you can see also axillary adenopathy depending on the locations of these diseases. And of course, you can always have just reactive adenopathy. Someone can have some kind of viral illness or something like that that's not HIV or other illness that could cause these. So, sorry, I want to go back here. So let's go back to the other question. So this would be a BI-RADS 0. Now, if you had multiple years of stability of these and a documented diagnosis like TB or sarcoid or CLL, then you can give it a BI-RADS 2. So if you have a documented reason, but when you have no other priors, as I didn't show you, and then I clarified that this was a baseline, you need to find out what's going on. You also have to make sure that these are really abnormal lymph nodes, because the way to best evaluate axillary lymph nodes is by ultrasound, not mammo. Sometimes we can see lymph nodes on mammo that look prominent, and we do the ultrasound and they're actually normal. So you always want to do an ultrasound. So you do a BI-RADS 0 and you get an ultrasound, like in the second question we talked about. Now, the hematologic workup only comes after you do a biopsy of these lymph nodes and you get CLL. So what you would do, you do the axillary ultrasound. If there are truly multiple abnormal axillary lymph nodes, you can do an FNA, which you have to send not just for regular cytology, but flow cytometry as well. You can also do a core biopsy of the lymph node as well for that. When the biopsy comes back as CLL, then you would recommend a full hematologic workup. Or if there's any sort of abnormality in the lymph nodes that suggests some kind of lymphoma, it can be other lymphomas too, you would do the hematologic workup. But you really want to do the axillary ultrasound and biopsy first. Next, we have a 40-year-old female with a strong family history of breast cancer presenting for a screening MR. This is the only image. I will go to the question. And 100% of people correctly answered linear ductal enhancement. So let's think there's a second question. So let's do the second question, and then we will go back to the images and we will talk about it. All right, and people answered DCIS and IDC, and the correct answer is DCIS, and we'll go back and discuss it, as I said, in a minute. But what's the next most appropriate step given the finding? And MR-guided biopsy, 20% of you answered correctly, it's MR-guided biopsy. So now let's go back and look at the images. So what you're seeing here is you're seeing a duct emanating from the nipple. It is definite linear enhancement in a ductal distribution. And then at the end here, you're seeing some non-mass enhancement that signifies probably some more abnormality in the lobule. So you're seeing a lobule, it's like a whole segment, segmental ductal enhancement. This is pathognomonic for DCIS. Now, the decision on what to biopsy. The decision on what to biopsy is done based on what modality you see it on the best. So we see the ductal enhancement on MRI. So we would biopsy it on MRI. You know, the assumption here is they've already had a mammogram and an ultrasound that were normal for them to go undergo this MRI, or a mammogram that was normal, I should say. Ductal and non-mass enhancement, we don't do a second look ultrasound for. Second look ultrasounds after MR are really best for mass enhancement or other abnormalities like abnormal lymph nodes. But when it comes to non-mass and ductal enhancement, it's not very likely that you're going to see something on ultrasound. So we tend to go straight to MR-guided biopsy on this. So the differentials for linear ductal enhancement on MRI is DCIS, papilloma, and fibrocystic change. So just because it's linear ductal enhancement doesn't necessarily mean it's DCIS, but it's one of the things in the differential, and it was the only choice from this differential in our question. But you can also see papillomas or papillomatosis look like this, and you can even see not quite this. This image probably would never be fibrocystic change. It could be papillomatosis, but sometimes fibrocystic change, you can see some linear ductal type enhancement as well. All right. So what we're going to do today is we're going to go through some breast imaging cases. So our first case is a 50-year-old presenting for an annual screening mammogram. This was her mammogram. And I'm just going to give you a brief moment to look over it because the next slide is much more important for the question. So here's her mammogram. And this is what the image you need to look at. So take a look at this. This is the image with the pertinent findings. All right, now we'll look at the question. And once you know the answer, you can feel free to fill in your answers. So it looks like the majority of people answered eggshell calcification and BI-RADS 2, and that is correct. And so these are oil cysts. So let's go back and look at them. So these are a benign finding. They are caused by fat necrosis, and we have these rimming calcifications that go fully around in 3D to represent like an eggshell. So what happens with oil cysts is they are fat necrosis. And so what happens with fat necrosis is there's traumas to the fat liquefies. Think of the liquefied fat as the egg yolk and the egg, the center of the egg. And then calcifications form around it, just like an eggshell would, right? And so that's what you're seeing here. These are oil cysts, which are a result of fat necrosis. They're described classically by BI-RADS as eggshell calcifications, and they are BI-RADS 2 benign.